Let's get started then.
Okay.
So welcome everyone. Good evening. Thank you for joining us for the February ASJ Journal Club presented by the Young Aesthetic Plastic Surgeons Committee. Tonight we'll be discussing the article Evaluating Postoperative Outcomes of Patients Undergoing Elective Procedures in an Ambulatory Surgery Center During the COVID-19 Pandemic. Tonight's session is sponsored by Allergan Aesthetics. We all know that Allergan's always been a strong advocate for aesthetic surgery education, and we really appreciate their support tonight. So a few reminders, please mute your microphone at this time. If you have questions, please ask them in the chat box or raise your hand and we'll call on you after our discussants are finished. And we'd love it if you turn on your video after to ask your question also. So tonight I'm joined by YAPS committee member, Dr. Denise Sarhadi, who will be fielding your questions and also incorporating our poll questions during the session. And we'll review all of those questions at the very end. So tonight we have the honor of having author Dr. Bill Adams join us. He's an international authority on breast implant research, and he's in private practice in Dallas, where he's associate professor at UT Southwestern and program director of the Aesthetic Surgery Fellowship there. He's founder and chief medical officer of the Plastic Surgery Channel, and he's currently the Aesthetic Society Education Commissioner, as well as the president-elect of the Aesthetic Society. Dr. Adams, thanks for joining us tonight. We appreciate it.
Absolutely, Mark. Thanks for having me.
So Dr. Adams is joined by his co-author, Dr. Rafael Couto. Dr. Couto completed his integrated residency at Cleveland Clinic, and he did his fellowship at UT Southwestern in aesthetic surgery. Dr. Couto has had multiple research grants, many publications, and he's currently also a member of the ASAP Young Plastic Surgeons Committee. Dr. Couto recently started private practice in his home of Puerto Rico. Dr. Couto, thank you for joining us.
Thank you for having me.
And finally, we have Dr. Brannon Claytor as our discussant tonight. And he also wrote the commentary to the article in ASJ. So Dr. Claytor is chief of plastic surgery at Mainline Health, and he's also in private practice in Bryn Mawr, Pennsylvania. He's an associate clinical professor at Lenkow Institute for Medical Research in Pennsylvania. He's president of Adipo Antibody Foundation, which is a company that investigates the capacity of human adipose-derived stem cells to produce antibodies. And he's also a member of the Aesthetic Society Covet Task Force. Dr. Claytor, thank you for joining us. So at this time, we'll turn it over to Dr. Adams to get us started.
Okay, well, thanks, Mark. It's great to be part of this. You know, these ASJ Journal Clubs are just fantastic. And certainly kudos to you, but the whole team, including Phaedra, who I know puts a lot of work into making these as great as they are. So let's go to the next slide, which is just our disclosure. This article, you know, was written by 3 people, myself, but also the person who put the most work in is with us, Dr. Rafael Couto, who was a fantastic fellow of ours and spent all last year with us, which was really, I think, a very productive year, but it was just a great time spending it with Rafa. And then Dr. Tom Wiener, who's just south of me in Houston. But none of us have anything to disclose with regard to this article. We can go to the next slide. Thank you. So what I'm just going to set this up, and then I'm going to have Rafa present the study data. But as you all know, in March and April of 2020, with the arrival of COVID, there was, I guess the way I would describe it, it was just a complete gong show in terms of what was going on, not only just across the world, but certainly with regard to our specialty. Surgeons were literally freaking out. There was hysteria. People's elective procedures were being canceled. And if you got on these chats, you know, literally the world was ending.
That's the thing. I spoke to the radiologist about it. And
can you mute your microphone?
I muted him.
Okay, great. I spoke to the radiologist. Well, we spoke to some radiologists too, but anyway, that probably was one of the hysterical surgeons. But, you know, people were just really worried about, you know, like their patient's skin was going to slough. They were never going to be able to do another elective procedure. And then to put fuel on the fire, there was a paper, a Chinese study that came out. Go to the previous slide, Phaedra. There was a Chinese study that was published that showed that there was a mortality rate, a COVID-associated mortality rate with so-called elective surgery of about 21%. So that was another thing that concerned people greatly, and Rafael will discuss it. But that study really had a lot of misleading conclusions and compared a lot of apples to oranges. So the impetus for our study was that we really needed to generate some good data on the safety of ambulatory surgery, and then to clarify the anecdotal and preoperative kind of screening and testing recommendations that many of our colleagues were just kind of throwing around without any evidence-based science to back it up. And with that introduction, I'm going to turn it over to Rafa, who's going to just present the study to you, and then we'll have time to discuss it.
Excellent. Thank you, Dr. Adams. Can you hear me?
Yes.
All right. So the objective of this study was mainly, one, it was to examine the post-op COVID-related complications in patients following elective procedure in an ambulatory surgery center during the pandemic. Another objective was to correlate that data with our pre-op screening and patient selection protocol. And the third objective of this study was to also share our protocol during this time, there was a lot of uncertainty and misinformation at that time. What we did is that all elective procedures performed at our ambulatory surgery center, it is called Park City Surgery Center in Dallas, Texas.
Can you go to the next slide? Yeah, and go to the next slide. Okay, go ahead, Rafa, because there we go.
Yeah, sorry. So all elective procedures performed at Park City Surgery Center in Dallas, Texas between March 1st and April 16 of 2020 were retrospectively reviewed. The primary outcome, as I mentioned in the study, was to determine, can you go back to the slide, the previous slide?
I'm really sorry. This is advancing itself. I'm not quite sure what happened.
Okay.
Here we go.
So the primary outcome, as I mentioned, was a study was to determine the incidence of COVID-19 related symptoms in patients and also personnel of the ASC post-op. And the predictive variables which are enlisted there includes age, ASA score, OR time, specialty, and also type of plastic and reconstructive surgery performed. Can you go to the next slide? So in the article, a detailed description of our screening protocol can be can be found in the article, but I'm just gonna mention a few pointers about it. 7 days prior to surgery, we would ask the patient to self-monitor by taking temperature and also check for any symptoms. 3 days. Go back. Yeah, 3 days prior to the procedure, we would ask the nurses to perform a telephone screening where they would use the most recent guidelines from the United Surgical Partners International. And then at the day of the procedure, patients and guardians had to wear masks at all times, with the exception of pediatric and incapacitated patients. Visitors or guardians were asked to wait outside the facility. Upon entrance, screening was made, and if the patients showed any fevers or symptoms, they were immediately isolated, and the procedure was canceled, and they would be asked to perform quarantine and follow the CDC guidelines. All personnel had to wear proper PPE and follow hygiene protocol. And lastly, there was a limited number of staff that were allowed to be present in the operating room during intubation and also during the procedure. Next. For the results, so a total of 300 consecutive patients were included in the study. Median age was 27 years old. The majority of patients had a score of 2. IV sedation, can you go back? Yeah, IV sedation followed by general anesthesia were the most common method of anesthesia. And the median procedure time was 47 minutes. As you can see in table number 2, procedures included in the study were multidisciplinary. Aesthetic and reconstructive surgery were among the 3rd and 5th most common procedure in this cohort. Next, please. Table number 3 shows the types of aesthetic and reconstructive procedure performed back then. The most common was liposuction, followed by mastopexy. The least common were ocpexy, breast implant removal, and also buccal fat removal. But most importantly, from the 300 cases that were performed, pre-op screening were only performed, and the outcome was like there was no reported complications. There was no COVID-19 diagnosis post-op, or there were no COVID-19 conversions among patient and staff. Therefore, so in conclusion, there was no COVID-19 related complications in a cohort of 300 patients after undergoing elective procedures at an ASC following strict pre-op screening protocol. Therefore, I mean, we can conclude that in this paper that with proper pre-op screening and patient selection, performing elective cosmetic procedure during the COVID-19 pandemic is safe. Furthermore, Dr. Adams shared recently that this institution or this ASC continues to monitor and to collect data following the same protocol, and they got over 4,000 cases and they have pretty much the same outcome. Now, regarding this
Next slide, go to the next slide.
Oh, sorry, next slide. So sorry. Now, regarding discussion, as Dr. Adams mentioned earlier, at that time, you know, during the outbreak, there was an enormous amount of information that was presented. Some were correct, but a lot were not. And back then, the only article available regarding post-op outcome during elective procedure was by Lay et al., which was a retrospective study of 34 patients that were diagnosed with COVID-19 infection following an elective surgical procedure at Wuhan, China. In their cohort, 44% of those patients were admitted to ICU and 20.5% died. They also showed that there was the age and comorbidities, complexity of surgery, and OR time were risk factor for ICU admissions, and they suggested that surgery and OR time was a risk factor for exacerbation and increased severity of the COVID-19 symptom. Now, when we read that article, we felt that there was, I mean, although it was very important and useful, there were three major flaws. One was that demographically and epidemiologically, it was very different to our setting. For example, that paper was just a few weeks after the first ever case reported in the epicenter of that time, which was Wuhan City. So most likely at such an early stage, the protocols for COVID-19 were not heavily implemented at that time. Secondly, we didn't knew, or in the paper they didn't knew whether the patient actually contracted the virus before or after the surgery, and most importantly, the almost 60% of those patients had at least one comorbidity, and also had and about a third of them had malignancy. So after we read that article, we felt that, you know, we had a lot of lack of data, like Dr. Adams mentioned, and that paper did not recapitulate it or sounded like a clinical setting of an ASC in the United States. There was a lot of factors that need to be taken into account. So that's one of the reasons why we took our paper. I mean, we did this study. Another thing was like the level of misinformation, and one of those is, I'm going to give you a perfect example. There was an incident of a patient back then that patient underwent a pituitary adenoma resection. Following the procedure, the patient and other 14 staff were tested for COVID-19. And this paper was, or this incident was cited in many articles, including a lot of even news media. And the only problem was that none of the healthcare personnel that were present in that surgery were among the infected ones. So they didn't knew if the patient was actually infected at pre-op. It got to the point that actually the surgeons of who did this paper, or who treated this patient, decided to publish this case report to clarify about all the misinformation going on. But anyways, that was the reason why one of the main reason why we decided to do this paper was to shed a light on this topic, because there was a lot of misinformation, and we felt, that we achieved it, because I mean we were able to clarify. I mean, we were able to use our protocol as a guidance, and I guess that's pretty much it. If you can do it, next slide, please.
Yeah, I think the next slides are Dr. Claytor's.
Oh, okay. All righty.
Well, Dr. Couto, Dr. Adams, that was really a great summary. Thank you so much. We'll now turn it over to Dr. Claytor for his discussion.
We need to unmute him. Okay.
Sorry about that. I had it muted. I just wanted to say thank you so very much. Can you go back one slide? There you go. Thanks so much. I think that it bears significant acknowledgement that Dr. Couto and Dr. Adams' contribution to the literature is incredibly significant, and they should be congratulated in this era of extremely confusing information, providing some data that would allow us to look at outcomes for our ambulatory patient population and demonstrate the safety and the ability to perform surgery safely. I think a couple of things need to be pointed out, and that is that when this paper was being put together, at least from the Aesthetic Society's perspective, we had not yet come together with our firm recommendations about the COVID recommendations when you were going to be doing surgery. And so they were way ahead of everybody else in terms of continuing to perform surgery at a time when many people were trying to figure out what were the best practices. And so they should be commended for tackling this in a manner that gave us something to look at. A couple of things that we should look at very significantly today compared to what was going on back in March and April is that their assertions that access to testing are very difficult were true back then. Now, testing is virtually universal and very easy to obtain. The second challenge was the reliability of tests back then as opposed to now, and the clarity of a PCR or nucleic acid amplification test versus an antibody test. And there was a tremendous amount of confusion that came out about these antibody tests and that they may be able to provide immune passports and so forth. And it's just clearly been totally debunked, and antibody tests are really only useful for epidemiologists trying to come up with population-based penetration of the virus and have absolutely no benefit for a patient trying to decide whether or not they are appropriate to proceed with surgery. So with the improvement of the negative predictive values of these tests, meaning their ability to determine that the patient is in fact negative as they proceed towards surgery, more and more data is available. And therefore, if a patient were ever to have a low sodium or a low hematocrit, these are very reasonable tests that we all perform on our patients before surgery, because we wouldn't want to find ourselves in a postoperative period looking backward in the mirror and say, oh, well, boy, if we'd only known this information beforehand, maybe we wouldn't have undertaken the surgery until we'd optimized them. The other thing that I think is important to point out is that Steve Teitelbaum put together a great paper, which has been reinforced by multiple other publications, that the incidence is about 1% of our asymptomatic patient population that gets screened, and that we're identifying these patients as positive. And so again, Dr. Adams' paper is incredibly significant for what they've demonstrated, but truly the number of patients being looked at is very, very small. And therefore, when you break that out into a larger population of patients, and by that I'm referencing a paper that Dr. Thorne put out earlier this year, where he assessed that it was approximately about 1.5 million patients are getting cosmetic aesthetic procedures every year. And if you assume that that 1% is consistent across the country, you're looking at almost 14,000 patients that would have been going to the operating room with positive COVID tests, albeit asymptomatic. And the question is, at what point do we want to be creating a culture of safety for not just our practitioners and our nurses, but also for our patients? And so really what this boils down to is what the recommendations are from our two societies, and the American Society of Plastic Surgery, as well as the Aesthetic Society, formerly known as ASAPS. Both came out with relatively strong recommendations that patients be tested prior to surgery. Now, the Aesthetic Society did have a caveat that said when testing was available, and I believe that testing is now so widely available that you could almost remove that recommendation. Furthermore, the American Society of Anesthesia very strongly recommends testing all patients before proceeding to elective procedures with the polymerase chain reaction test. And so those are our societies, as well as the Society of the physicians who provide our anesthesia care. And if you could fast forward or go to the next one, Phaedra. And then this is a paper that just recently came out. I was talking to my infectious disease colleagues today, and they shared this with me. And this is a study that came out of Europe, mostly from, if you can go back, it's mostly from England and Spain. And this is their review. It's a large meta-analysis of hundreds of thousands of patients, and they are finding upwards of 30% of patients infected with SARS-CoV-2 are actually asymptomatic. And so what this really boils down to is kudos to Dr. Adams and Dr. Couto for really pushing the envelope and creating some phenomenal data so that we can start to have a conversation about this. But I think that in this era, when we're looking out for the undisputed safety of our patients, as well as our staff, providing that degree of patient confidence that has really allowed aesthetic medicine to virtually explode in the last 6 months has been because patients are confident that we are able to protect them in this era of these new concerns with a test to demonstrate to them and to the surgical teams that they're not actively infected, albeit asymptomatic. So with that, I'll wrap up and turn it back to Dr. Albert.
Thank you so much, Dr. Claytor. So I guess I'll start us off with a quick question, if you don't mind. And Dr. Adams, I'd love to hear from you. Since we've had the opportunity to all live through COVID since you published this, is there any recommendations that would be different from your perspective, or are things essentially the same in your mind?
No, I mean, I don't think I'll have anything different, but all I would say is that, the proof is in the pudding. So when we published that paper, it was 6 weeks of cases in a very early time period, but now we have the same experience, but over 4,000 cases. So this notion, I really don't necessarily agree that you should be doing mandatory PCR testing in every patient preoperatively, because simply we haven't done that for 4,000 cases and there have been no problems. You can even look at asymptomatic cases. I think there are probably quite a few patients that are asymptomatic, but if they're not sick, when you screen them, they are not going to have a problem. 35% of patients with the flu are asymptomatic. and over the years, we've operated on many of those that basically aren't febrile and aren't sick. And it's just not an issue. Anecdotally, we have actually know that we've operated on one COVID positive patient that was asymptomatic. And of course, she did fine because she wasn't sick. So what we've learned is what's important is the patient sick or having symptoms at the time you operate on them? Furthermore, what I would say, I don't believe that just because testing is more available doesn't mean it's any better. The false positive rate and false negative rate of these tests, aside from the company who develops them and tells you they're really good, are not great. And there's a lot of variability in how the tests are taken. So I just don't think it makes sense based on our data to mandatorily test everybody. So what do we do now? We do the same screening protocol Rafa presented, but there are specific risk groups of patients that I will test patients. So for example, if I have a nurse, particularly I had a nurse that worked in the COVID unit at one of the hospitals. Obviously, we did preoperative testing on that patient, and I think that would be a subset of people I would agree would be testing. But based on our data, I think that testing is not needed. I think you need to just screen people.
I just wanted to clarify. You had mentioned that you guys operated on someone who's asymptomatic but had a positive test. Is that? Do you mind just clarifying? I mean, is there anything that we can garner from that?
Yeah, I mean, the story behind that patient was she came in, went through the usual screening. Her husband actually called in during her like 6-hour mommy makeover procedure and said that he actually was with her preoperatively, and he said that he wasn't feeling that great, and he went to his doctor, and the doctor had tested him. He was COVID positive. So when I called him after the surgery, and kind of aside, but I said, what's the deal? He said, well, I've been feeling achy since Saturday. And I was like, well, why didn't you fill that out in your screening? Because, the caregivers get screened as well. And he's like, well, it didn't say body aches. And I was like, well, do you know what malaise means? Because that's what it said in the screening. So anyway, when the patient woke up, we had her tested and she was positive. But the thing is, her screening, she was afebrile, had no symptoms. She actually never had any symptoms, but she had a positive test. And she was operated on with asymptomatic positive test for COVID.
Well, that's valuable. Thank you so much. I mean, we have a lot of esteemed colleagues joining us tonight. If anybody has any comments, we'd love to hear from you by video or ask a question in the chat box. Denise, any questions on your end at this point?
So we've had a couple, Dr. Adams, thank you so much, everybody, for Dr. Claytor and Couto for this. We have a couple polls that have gone out already, and it looks like 100% of our attendees tonight do screen their patients just for symptoms, and about 90% screen with a PCR test, which, as Dr. Claytor mentioned, was part of our society's recommendations. And I think the biggest question at this point is, what is the implication of knowing that 30% of COVID positive patients are asymptomatic but can spread it, and feeling somewhat that PCR tests are tests that put down on paper whether or not someone is actually sick? What is the implication of that long term? We want to keep our staff safe. We don't want to lose cases. What is the risk of doing too much, I suppose? In terms of testing.
Well, I mean, I can tell you what my perspective is, Denise. I think that every surgeon's got their own perspective, and I don't think there's one right answer. I think you have to do what you feel is the right thing for your particular patient. The problem is that, just to have dogmatic recommendations, I just don't think that that's the right thing for everybody. And so we kind of, the protocol we presented is kind of what we do for people, and we do testing in a select number of patients that we feel like are at higher risk, and that served us well.
And also, may I add something as well? I mean, I think the crucial thing is proper, in addition to pre-op screening, is also proper PPE for the staff and everybody around, because, doing PCR testing in an academic institution compared to a private practice is a big difference. I mean, institution, you can have that test immediately within 72 hours, or maybe even 24 hours, or sometimes in 1 hour. In a private practice setting or a ASC, you send these labs to LabCorp or Quest, and they can take up to 5 days, 7 days. How can you be sure that the patient is going to be quarantined, or they're not going to be exposed during that time? So at the end, it comes down to protecting yourself and wearing proper PPE. Whether it's positive or negative, you still need to wear proper PPE, because you don't know if the patient's actually, is a carrier or was exposed after getting the test done.
We have a question from the audience, from John Decorato, and he asks, with current recommendations from the societies regarding testing, how do you protect yourself legally if you're not testing?
Well, I mean, we have a peer-reviewed published paper that doesn't test, and I unless I'm mistaken, I think that the Aesthetic Society guidelines are not mandating testing. They're saying that you may consider testing if it's available, but there is no standard. There is no given standard from any entity. There's only recommendations.
Can I make a comment?
That would be great, please.
Hi, this is Steve Teitelbaum, and I wrote with Robert Singer and John Diaz in January ASJ report of a survey in LA where we had 112 members of the LA Society of Plastic Surgeons respond about what they had done with 5,600 surgeries. 92% of the surgeons were doing testing, and all of our hospitals in the LA area require testing. I think that if the hospitals in your area are requiring testing in your community, I don't think that we should be doing something that someone could argue is less than what the hospitals and outpatient clinics are doing. And if that's not what it is around in your community, then that may be a different situation. The second point I'd make is that at the time that those 300 cases were collected, there were very few cases within Texas. We made a big deal in our paper that we collected cases in July and August of 2020 when there was a surge in Los Angeles. But that surge in Los Angeles is nothing compared to the surge that happened in December in Los Angeles. So a lot of this ultimately depends on what the rate is in your community. And if the rate is high enough, some asymptomatic patients will get through the screening. They may infect someone in your office, and we still don't know for sure what their fate will be undergoing anesthesia. Bill's case of the person who unknowingly was operated on, who was positive, is a great case. We have too few examples of those. Ultimately, to know surgery is safe for a patient with COVID, you have to operate on known COVID positive patients. It's like you don't know a bike helmet protects you if none of the bike riders had an accident. You need bike riders with hitting their heads to know the helmets help. So I strongly would urge people to, at a minimum, do what's being done in their community. And I see no reason not to test given how available it is. We now do it the day before surgery with a lab that will get a PCR result back that night.
Steve, what I'd say to that is that, we've been doing surgery for a long time. And again, it's a known fact, 35% of flu patients are asymptomatic. So we're operating on those flu patients because they're asymptomatic, and none of them are having problems. and this is no different. So I think, again, the screening is the most important thing. If you want to test because it makes you feel better, I think that's fine. I certainly agree with you. If you're operating somewhere where it's requiring testing, I definitely would follow those policy recommendations. But I mean, the proof is in the pudding, and again, we did do that study during the early phases of COVID, but again, in Texas, which has not been one of these kind of big lockdown management strategies, we've had two large numbers of caseloads of COVID, both in July and then December and January. But we simply haven't seen any difference in the outcomes at the center that I operate in.
Bill, I would tell you two statements. First, to say that COVID is no different than flu. Imagine saying that in a deposition. Imagine saying that to any other scientist. People would look at you like you're crazy. You don't know enough to know that COVID is no different than flu when it comes to perioperative risk to the patient and risk to your staff. And second, I'll say again, if the surgery center across the street from your office or a block away or a mile away, or the community hospital where you are is testing, I think as plastic surgeons, we want to give the image that in our private, safe, quad A or triple A operating rooms, we are at least as safe as is what is going on in the more established centers.
So it looks like we have another question from the audience. This is from David Stevens. Knowing that many patients may be asymptomatic or test negative prior to the time of their procedure, what is the recommendation for reducing risk to the patient of complications and spread for the staff? One strategy is to have the patient gargle with mouthwash and use nasal irrigation, particularly in head and neck surgery. Any other strategies? Dr. Claytor, as a member of the task force, any thoughts on that?
Thanks so much, Dr. Albert. No, those have not been shown to be successful.
What I know is that dilute betadine is actually virucidal and very good in locally being an agent to use people to gargle with and rinse out the nose. So I actually know quite a few rhinoplasty surgeons that really use that protocol. Both preoperatively, they have the patients mix betadine with mouthwash and gargle with it, and then they prep the nose, with betadine as well. And that there's not any incredible level 1 data on that, but I do know that a lot of the rhinoplasty surgeons, at least around this area, use that protocol.
And it may become an interesting factor, as we know vaccinated population can still have COVID living in their nares. So I know there are a number of antiviral nasal.
Yeah, actually, that's a misnomer too. There was just a Israeli study that disproved that, and what they showed actually was a number of things, but they were actually looking at the vaccine and the doses and the level of antibodies, and what they found was when patients get the second or individuals get the second dose of COVID vaccine, that they get 6 to 20x times the number of antibodies they have after the first vaccine, and that that level of antibodies is far higher than patients who actually have had COVID. And then the caveat to that they commented on is that the level of antibodies that people have after 2 levels of vaccine is incompatible with any live viral activity in the nasal passages, like people have kind of anecdotally said occurs. So basically they concluded in that study that people after 2 doses of the vaccine would be unable to transmit the virus or harbor that in their nasal passages.
So how are they claiming that those who are vaccinated can still, be a carrier for the virus through another?
That's like, Mark, that's like maybe 1,000 other claims I've heard in the past 9 months that have absolutely no science behind it, but people just kind of spout out like it's the Bible. And so there's a lot, I think there's a lot of anecdotal claims, and that's one of them. but there is no data to support that, but there is some data to refute it.
Thank you. Any other poll questions that we want to go over, Denise?
I'm waiting on results from one more question. And it hasn't come through yet, so.
Well, any other questions or comments from anybody? We'd love to hear from you now before we review the last poll question and wrap things up.
I think that's the one you wanted.
Yeah, I think so. Let's see. So one last question was, have you had to cancel a surgery because of positive COVID PCR antigen test in an otherwise asymptomatic patient? And 83% of our respondents said yes. And then we looked at the number of cases people have had to cancel, and about 77% have canceled about 1 to 5 cases. 10% of our attendees tonight have canceled 6 to 10 cases, and about 13% of our attendees have canceled more than 10 cases for a positive COVID test in an otherwise asymptomatic patient.
All right. Well, if there are no other questions or comments, I'd like to conclude by giving a whole lot of credit to Dr. Adams and to Dr. Couto for publishing all this data so early and really be ahead of everybody on this topic. So thank you so much. Also, a big thank you to Dr. Claytor for all the work you've done on COVID-19 and plastic surgery. Thank you all for joining us tonight. I would also love to thank ASJ Executive Editor Phaedra Kress for all of her work in making tonight's such a success.
Always.
And thank you to Allergan for sponsoring this event. So tune in next month in March for the ASJ Next Generation Editors Journal Club, moderated by Dr. Ryan Austin. And we'll be back again in April for the next YAPS sponsored journal club. Have a great night, everyone. Thanks so much.
Night.
Thank you.
Thank you. Good night.
Bye.
Good night.